live from beautiful and very hot Grand Junction, Colorado. So thank you to everyone who came in person. Really appreciate your perseverance tonight. Thank you to everyone joining us online as well. We're here tonight to talk about MS with Dr. Andrew Wolf. I'm Kelsey Morrow, Education Manager at the Rocky Mountain MS Center. I would also like to thank the pharmaceutical companies who have provided patient education grants to support this series. Thank you to Biogen, Genentech, and Novartis. This speaker series is just one piece of our education programming. We have a variety of formats available to you, including both in-person and online options, with most of our programs also available on demand through our YouTube channel. This is where you can find our most recent webinar featuring Dr. John Corboy discussing the DISCO MS extension data and other MS research updates. We also have a fun series called Topics in 10, where you can learn about specific topics in a short time frame. Our latest episode covered insurance basics with Dr. Kavita Nair. And the next event in this Q&A series will feature Dr. Enrique Alvarez on August 18th in Denver and online. We announce all of these educational opportunities through our mailing list, our Facebook page, and you can sign up for notifications through Eventbrite. All of our education programs are free of charge to anyone interested. And now I'd like to introduce Dr. Andrew Wolf. Dr. Wolf attended medical school at the University of Colorado Denver School of Medicine and completed residency and fellowships at the University of Colorado. His research interests are focused on improving the treatment of patients with MS and other inflammatory diseases of the central nervous system. Current projects include developing digital and blood biomarkers to detect worsening in MS patients, characterizing clinical outcomes of neuroinvasive West Nile virus infection in patients on anti-CD20 treatments, and understanding the risks of immune checkpoint inhibitor use in patients with neuroimmunological diseases. He is also interested in the acute management of demyelinating diseases and optimizing inpatient to outpatient care transitions. We did have a lot of great questions asked at registration, and we will get to as many of them as we can. You can ask new questions by typing them into the Q&A box or by raising your hand here in person. In person, I do ask just wait for me to bring the microphone to you so that our online viewers can hear your question as well. And then all decisions regarding MS treatment and medications should be discussed with your own neurologist. This is just for informational purposes. With that, I'll hand it over to you, Dr. Wolf.
Do I have to turn this one on?
Yes, you're good.
All right. Well, thank you everyone for being here. Thank you to Kelsey and Sophie for setting this up. Unfortunately, I heard this is Sophie's final event that she's organized, so we can give her a round of applause at the end and embarrass her. So my name is Andrew Wolf. I'm one of the neurologists at the University of Colorado. So we have a pretty big group of people these days who specialize in neuroimmunology. So what that means is multiple sclerosis and then other inflammatory diseases that will impact the brain and the spinal cord. And so we all split our time between research and taking care of patients and doing education for medical students, residents, and so forth. But it's great to be here. It looked like the other big 6 o'clock event at this venue was the hula hoop contest. So I don't know that we'll have as much fun as they will, but we'll try to at least be informative. All right, so I'm going to run through just the questions that we had submitted, just with some framework. And then like Kelsey said, if you have additional questions, write them down, raise your hand, we'll run through them at the end, or for the online people, throw them in the chat and we can make that work. But we should have plenty of time to have a good discussion here. All right. So the first question that I got, so it says, can you tell us more about smoldering MS? And so smoldering MS is a little bit nebulous of a concept, but smoldering MS, what we really think of that meaning is just inflammation that is sort of low degree of activity, sort of like a fire that's not raging, but is just sort of burning with some embers, but can still be damaging. And so it's not really a technical term, although some of the drug companies have started to use this as a marketing metric or a marketing campaign around calling things smoldering. And so it's probably helpful best to just think about types of inflammation in MS just to begin with, and then also how that relates to the different types of MS that we currently characterize people as having. So the majority of patients that get MS will have what we would term relapsing remitting MS. And so that is probably about 80% of patients traditionally. In that type of MS, people typically have attacks where they have these really acute episodes of inflammation. Typically over a couple days, they notice new symptoms, and they typically will show up to the ER or to a neurologist and get diagnosed. And when we look at the MRI scans for those patients, we see typically new lesions that will light up, demonstrating that inflammation in specific areas. So that's most patients, that's not every patient. A minority of patients with MS will get diagnosed with what we call primary progressive MS. So in that case, they'll often still have lesions develop in the brain and spinal cord, but they will not typically have attacks where they show up with like these really quick onset of symptoms. By definition, they'll typically have symptoms that develop over about 12 months. And so that we think the types of inflammation are different that are going to cause progressive MS versus these attacks and relapsing MS. So I think really when we think about smoldering, we think that some of that progressive inflammation is happening not just in those primary progressive patients, but also in patients who have the relapsing MS. And that sort of inflammation, which we think might be mediated by a type of brain cell called the microglia, which we can talk a little bit more about with one of the other questions, may not respond as well to some of our current MS drugs. So that is sort of the idea, is trying to put a label on types of inflammation that are not responding to medications as well, that are making the patients feel worse sort of slowly over time. But not really a totally technical definition at the moment. So then the next question sort of nicely segues. It says, please share about some of the most exciting cutting edge research that is happening. So the third question also asks about something called a BTK inhibitor. One really exciting thing that we're thinking about over the next probably 6 months is we may have a new medication to help treat MS. So there's something called the BTK inhibitor. So BTK stands for Bruton tyrosine kinase. So that's an enzyme that lives in several of your cell types in your body. We know that it lives in the B cells, which are an important component of inflammation in MS. And we also know that it lives in a type of cell called the microglia that I had just mentioned. The microglia we're increasingly interested in as a type of cell that is misbehaving and causing these slow development of MS lesions. So BTK inhibitors have been around for at least 10 years. They have not initially been used in MS, but they were used also to treat B cells that were growing out of control. So in diseases like lymphoma, leukemia, BTK inhibitors have been used, actually with great effect at slowing down those diseases. The versions that were used to treat cancers were too toxic, so too many side effects to use as MS medications. So over the last 10 years, the drug companies have been making new BTK inhibitors that are better tolerated. And so a few of those have actually completed clinical trials, specifically in MS patients. And so one of them, which is called tolebrutinib, which I can write down on here a little bit later, that has finished studies both for patients with relapsing MS as well as for patients with secondary progressive MS. And so that drug did not really show benefit compared to Aubagio, which is an already existent MS therapy for relapsing MS. But it does look like the drug was helpful at slowing down progressive MS symptoms. So in that group of patients that had secondary progressive MS, tolebrutinib reduced how much disability those patients accumulated over time. And so that was an exciting result. There's still some things that we don't know about just from the study, although it's been published. It's going to be reviewed for approval by the FDA. Hopefully in September was the plan. And so if everything looks up to speed from that standpoint, we may have that drug available towards the end of the year or towards the beginning of 2026. So that would add something new to our MS treatment arsenal. I think as far as things that are not quite as far along, there are several other BTK inhibitors that are currently in clinical trials that we are part of at the university. Some of those are being compared directly to some of our other MS medications, so it may help us understand how effective is this compared to what we actually have, as well as if some of these other drugs are safer or more effective than tolebrutinib. But we'll have to wait on those results over the next probably 12 to 24 months. I think the other thing trial that from a research standpoint that we are rapidly building up is for something called CAR-T. So I'll actually write these down real quick. Don't think this marker's super dark. Yeah, so CAR-T stands for chimeric antigen receptor T cell. So fancy acronym. Again, we like to steal all of our best ideas from the cancer doctors. So CAR-T is a mechanism that has been used to treat blood cancers for the past 10 years or so. What this technique does is it can actually take out T cells, so a type of white blood cell from patients, and then it can take them into the laboratory and then reprogram them to be basically like little missiles that go and bind inflammatory cells and kill them. So the idea is that this may be a very, very effective drug to reduce the inflammation associated with MS. We think just based on these being cells and not antibodies like some of the other medications, they may penetrate better into the brain and into the spinal cord and really dramatically reduce how much inflammation is happening. These studies are still much earlier as far as how far along. I would estimate, just since we're part of the clinical trials, I think there's probably been fewer than 20 patients internationally that have received CAR-T as part of these studies. But we're very hopeful that they might, again, give us a more powerful anti-inflammatory medication for MS. So we'll make that a little bit darker. Okay. And then we have one other major study that is happening, which is for a drug called Frexalimab. And so that drug works both on what we would call the adaptive immune system, so working on these types of white blood cells like T cells and B cells that most of our current MS therapies work on, as well as looking at the interactions with something called the innate immune system, which we have not really been able to adequately target for our MS patients. So we're hopeful that that drug may also provide some benefits compared to the medications that we currently have. So anyone interested at all in clinical trials, definitely reach out to us. We can get you in touch with the correct people at the university.
Think of a regular mic.
Oh.
Yeah. Yes.
I have a question for the BTK inhibitors. Is it something that you do in combination with a DMT or it by itself?
Yeah, so that's a good question. So the question is for BTK inhibitors, are those used as monotherapies, meaning just that's the only treatment, or are they used in combination with any other sort of current MS medication? So the way they're being tested is as monotherapies. So people get either the BTK inhibitor or a placebo, or they get a BTK inhibitor or one of the traditional MS drugs. Typically, that's been either Ocrevus in some of the progressive trials, or teriflunomide, which is Aubagio in the relapsing trials. I think though you bring up a good point. I think one thing that's not been probably explored adequately in MS since the 1990s is we haven't really done any studies of combination therapy. So we have one drug that works one way and another drug that works another way that might complement or provide synergy. Would it make sense to have a patient on multiple drugs? I think the answer is yes. I don't think we're ever going to get the ability to do that without doing the clinical trials just from the insurance standpoint. So I don't know, what these BTK inhibitors will look like from a price point. I'm sure they'll be very expensive, like all of our other MS drugs. The BTK inhibitors that are approved for cancer is probably, the list price is probably close to $100,000 a year, which isn't, too different than drugs like Ocrevus or Kesimpta, which, are a little bit less than that typically. But I think, safety-wise, both medications and different versions of these drugs have been used with rituximab, which is a drug similar to Ocrevus for cancer patients. And we know does not appear to be any sort of catastrophic side effect that has happened. Those patients are much sicker, and of course, there's risk for infections and things like that when we're manipulating the immune system. But I do think we will see a combination study in progressive MS, especially that will probably be happening at some point in the next couple of years. So good question. The second part of the question that was written down on here was just a new drug for secondary progressive MS. So just to make sure that we're on the same page. So I'm not 100% sure that tolebrutinib will get approved, but this is the drug that will likely be approved for secondary progressive MS later in 2025. And there's a question about pregnancy in MS. So there was a question just about specifically with BTK inhibitors. So BTK inhibitors, we don't have any data on using them in pregnant patients for the MS trials specifically. Pregnant patients were not permitted to be in the studies. The older versions of BTK inhibitors used for cancers are thought to actually be very dangerous for fetal development. So those would, probably be a no-go during pregnancy. We typically don't treat our patients during pregnancy. There's one drug that we traditionally would continue, which is glatiramer acetate, which is Copaxone. So that drug is thought to be safe to use during pregnancy. At least at our center and in my practice, we typically try to have patients on B-cell depleting drugs if they're thinking about getting pregnant. So especially Ocrevus, ocrelizumab and Kesimpta, ofatumumab. And then we typically just hold the medication while patients are pregnant. That tends to actually work very well and does not appear to pose any significant risk to the fetus. Tysabri, which is another antibody drug, so natalizumab, that drug can also be used during pregnancy, but that certainly would require some expert input about the timing of that, because we don't like to, at least personally, I don't like to do that towards the end of the pregnancy, just because there can be some issues with the blood development in the baby. But just things to think about. So we're always happy if anyone has questions that's seeing a general neurologist or elsewhere, we're always happy to help them with those decisions. Okay. All right, and so we talked about medication. So that was the next question. And then speak about any new and upcoming advancements and treatments. So we talked about that. Question we get pretty much every time is what's new about remyelination or building new myelin. I'm hopeful that one of these times I'm going to be able to answer that we have a major development along this question. Right now we don't, but I think there's a few things that are in progress. Yeah, this has been a topic of interest in MS, for a long time, because we have gotten, over the last 10 to 15 years, actually really good at slowing down relapses from happening. We've had treatments that are helpful with progression, although we can't necessarily stop it, but we still don't have any sort of medication approved that we know can go in and sort of help the nervous system repair itself. There's been a lot of things that have been tried to help with remyelination, just not a lot of things or really anything that has clearly worked. So there's a couple of clinical trials that are happening looking at drugs that are aiming to sort of ramp up the body's remyelination pathways. So there's one with a drug called clemastine. Clemastine is an antihistamine drug. Not clear if that's going to work, but it's shown some promise in some smaller studies. And then there's one with a new novel medication called PIPE, PIPE 307. So that's also in a clinical trial. And the hope is that these medications would help the body sort of ramp up their natural ability to repair the myelin, which is damaged by the MS attacks.
Dr. Wolf, do you have any specific update on PIPE 307? It was one of the questions submitted.
I do not have any specific update on PIPE 307 because we are not part of the clinical study at the university, so I cannot comment specifically on where that may be. I believe that one of the groups in Colorado Springs Neurological Associates, may be a site for that study, but we are not. The other thing that we have been working on at the university is something called a vagal nerve stimulator. So the vagal nerve lives outside of and flows back in and out of the central nervous system. So people have used vagal nerve stimulation with electricity for a long time to treat things like epilepsy. The thought is that if the myelin's been injured, we know that myelin can recover to some degree based on electrical stimulation that's been shown in animal models, like with mice and something called zebrafish. And so the thought is that for MS patients that have had injury, especially with motor deficits, that stimulating the nerve at the same time that they do motor tasks can sort of strengthen and reinforce those pathways by helping the myelin recover. Not proven, but there's an early stage study that we are doing at the university that is looking at that specifically. Okay. Next question is on diet and physical training. So there's always a lot of questions about diet. We do not have a perfect MS diet. I think what I typically recommend to my patients is the same sort of diet that gets recommended basically by every doctor in every medical condition, which is the Mediterranean diet. And I like it for a few reasons. One, it's been proven to help both with MS-related fatigue as well as cardiovascular health. So this is the diet that the cardiologists are always putting people on. And I think one thing we worry about with MS over time is that although some worsening symptoms with age are going to happen directly from the MS, some of the symptoms are also going to happen just from accumulation of other health problems. So high blood pressures, diabetes, obesity, etc. And so the Mediterranean diet boiled down is really just, eating things that look more like natural foods. So less processed foods, limited grains, but more whole grains when you eat them, more fruits, vegetables, and lean meats. And I think that, that typically is not too restrictive. I think even if we gave people, even if we knew that there was a perfect diet and it was super restrictive, if we gave it to most people, including me, we would not be able to follow it. So this is, I think, a happy medium about things for us to do. As far as physical training, oh, sure.
You familiar with Dr. Swank's diet? Diet for MS?
Say that again, sorry.
Dr. Swank, University of Oregon.
Dr. Swank.
Yes. His research was going on since about 1947. His is mainly the low-fat type of diet, what we eat, studies of beer and wine cultures versus, wine and oil versus beer and wine, fat cultures. So the type of fats, that was his main emphasis that we eat. And
yeah, so there's the question just about diets with modified of different types of fat contents. I don't know specifically that diet. It sounds like it was from someone up at the University of Oregon or OHSU. I don't know. I'm happy to take a look into it, and we can perhaps send out like an email, but I don't know that one specifically.
Yeah, he has a full website. But yeah, he was kind of the guy.
Okay.
Studies of culture. So
okay. Perfect. So physical training. So I think, we actually know that exercise can help release chemicals in the brain and the spinal cord that can help grow new connections and repair cellular injury. So including something called BDNF, brain-derived neurotrophic factor. So regardless of the vascular, issues or feeling good from exercise, we do know that it has a direct impact on brain health. So we typically do try to have our patients do some form of regular physical activity. Um, this does not have to be something heroic, especially, with patients with different mobility limitations, but, really anything to get the heart rate up or doing some combination with strength training can be helpful, but nothing that has to be fully like regimented as far as we can, give you a directed, perfect plan. Okay. And then we had a good question, I think, for today that I'll probably combine with another one, which is what causes patients with MS to have heat intolerance? Does it typically get worse or more sensitive with age? Um, so heat intolerance is a quite classic symptom of MS. It was described quite a long time ago by a neurologist named Youthhoff. So you hear it also referred to as Youthhoff phenomenon. The reason that patients struggle often so much with heat just relates to actually the physics of how the brain and spinal cord cells are working with that myelin damage as the body temperature changes. So back, a long time before I was doing this, before people had MRI readily available, one part of, if you look back at MS diagnosis in like the 1960s, for example, was actually like examining patients, testing their muscle strength, putting them in a hot water bath, and then repeating the exam and seeing how much worse they got. Because almost invariably patients would get much weaker and feel worse, because of these heat associated changes. I'm not aware specifically that, just as age alone would cause this phenomenon to get worse. But of course, if the MS gets worse, if there's more injury, this may be a more prominent symptom. I think especially for women, we also hear that a lot of this is sort of exacerbated by menopausal type changes. That is an area of research that, I'm very hopeful will be, explored more in the next couple of years, just as we've gotten better at sort of the early stage of the life cycle with managing things like pregnancy and breastfeeding, but not a lot on the later end with menopause, although that is a very common question that I get in clinic. So I think, the question is sort of what to do about heat intolerance. I think unfortunately we don't have a perfect answer for it. We typically sort of go at it in a two-pronged approach. So one thing would be environmental. So part of that is living spaces or built environments that are better cooled and things like that. The other, we have a lot of patients that will use cooling vests, whether passive that just have ice packs or cool water in them, or even active cooling with fans and things to try to tolerate the heat. But those things often are sort of time limited as far as they don't provide a constant source of dealing with this. So on days like today when it's close to 100 or over 100, it can often be, I think, quite challenging. I will often at least try some my patients that really struggle with this on a medication called Ampyra, which is Dalfampridine. So that medication is not approved for heat intolerance. We're not sure that it works, but it is approved to help with walking speed in MS. So Ampyra has been around for about 15 years. The reason that it may work, and there are at least some small studies supporting this, is that it helps regulate how the brain and spinal cord cells fire, makes it a little bit more regular. So the thought is that it might help if they're sort of short circuiting because of the hot weather, but not proven. Generally a pretty well tolerated medication though. So if people are really struggling, it's usually worth a shot, and I try it quite frequently for this cause. Okay. And then the next question here, so specific characteristics of MS-induced fatigue compared to fatigue caused by other things, including illnesses. Any tips for getting through days that end up being busier than planned and like hits of severe fatigue? So also a good question. I think, fatigue is a symptom that we struggle with managing a lot, and that our patients, have to deal with, I think, in spite of our best efforts. And so we don't entirely understand why MS patients have so much fatigue. There's, an approach that I always think through, which includes a couple things. So one, I would certainly acknowledge that even if someone is otherwise perfectly healthy, has no stress, and is sleeping, 10 hours a night, that often I still hear that they have fatigue. So we know that that is, often related just to the MS. In that case, we typically will try medications to help with it, including things like modafinil or Ampyra, which I had just mentioned. Neither of those things are proven by clinical trials to work, but I certainly have patients that do better on those medications. And then the other part is, to try to optimize all these other things that might be impairing sleep, for example, sleep apnea, nerve pain, waking up multiple times per night to go to the bathroom, because I think probably the more common situation that we run into is people are only sleeping 4 or 5 hours a night because of some of these reasons. And then, of course, there's going to be an added issue with fatigue on top of what the MS alone is causing. We think about other medical issues, sort of separate from MS that can be a problem. So thyroid disease, for example, being one that we often will work up. We think about medications. So if someone's fatigued frequently and we have them on a bunch of medications for nerve pain, well, those can certainly, make fatigue worse. So that's something to think about. And then we think about mood symptoms. So depression, anxiety, those can also contribute to fatigue. So we like to try to address all of these things, but, we're always acknowledging that we know that MS just in and of itself is going to cause fatigue, but we don't at the moment have a medication or a treatment at all that's specifically targeted to help with that. And it looks like a question.
Are you seeing artificial intelligence becoming a tool for your center?
Oh, sorry, I can't hear all the way up here because the fan blowing, but some artificial intelligence.
Are you seeing artificial intelligence becoming a tool for the MS center?
So yes. So artificial intelligence has been a helpful tool for a few things. I think the most prominent way that we are using it is in image analysis. So for patients who get their MRIs at the university, we now have a tool that runs on the MRIs called icometrics. And so that really does a couple things. So one, it will take the MRI and it will analyze it and it will measure the brain volume. Although it's a noisy metric that we don't quite know how to use, we do know that brain volume changes, where the brain volume decline is probably a useful marker of tracking the disease with multiple sclerosis, disease progression with multiple sclerosis. So that's one way that we use it. The other things that are kind of cool that icometrics will do is it will actually count or attempt to count all of the lesions in the brain and then add up, how many are there, and then, how much volume are they taking up. And that's actually helpful for us, to make one is a quality control. So we, of course, look at the MRIs and read them, and our radiologists read them. But it does, provide sort of a printout for us and says, like, there's a new lesion in this area of the brain. And then, if we hadn't seen that, we like to go double check. For any of you that get your MRIs at the university, this is far from perfect. So I would say, probably 8 out of 10 times that it says there's a new lesion that I go look at it and there's actually not anything there. So I don't think the AI is probably going to be taking the radiologist job like anytime in the near future. But I do think it's useful to track things, with the brain volume and then, as a quality control. Probably less important, but we also like to use AI for, to help expedite different tasks like writing appeal letters to the insurance and things like that. It actually makes that way easier to sort of fight back more efficiently against them, which I, of course, enjoy doing. But Yeah, but I'm sure there'll be much more sort of, forthcoming from the AI standpoint.
My question is there any any advancement or new research for like early detection or for like genetic testing for younger people to see if they're more susceptible to MS?
Yeah, so the question is about early detection of MS, potentially genetic testing. So probably the biggest research effort for this, there's a study that we're doing. There's an adult arm and a pediatric arm. So the adult, the arms are called Rise and Dreams. So these are looking at first degree relatives of patients with MS and doing genetic testing and MRIs to look and try to determine genetic risk factors, and then understand like what are early changes happening with MS. We don't think of MS as being a particularly genetic disease. There's probably a couple hundred genes that have a small influence on the risk. Even for identical twins, with the same DNA, if one of them has MS, the risk for the other one getting it is about 1 in 3. So it's not, like some diseases where there's a single gene or a single, confirmed pattern where it will make it 100% inherited. And just sort of put that in reference, the risk of MS, just if we, took everyone in the US, is probably about 1 in 250, something like that, 1 in 300. That number keeps going up, so you'll see it quoted differently at different points. The risk for a first degree relative of someone with MS is probably about 1 in 30, 1 in 40, somewhere in that ballpark. That changes a little bit. We know women are more susceptible to getting MS for reasons that are not entirely clear, but about 2/3 of our patients are women. So that's one research study, with us with genetics. There's not typically recommended, outside of the research setting, anything for people who may be at risk just by family members, besides trying to modify the things that we know are MS risk factors that are modifiable. And so the ones that we think about, one is vitamin D deficiency. So I often will tell my patients who ask about their kids, is just to check vitamin D and perhaps put them on a vitamin D supplement. We don't entirely understand why vitamin D deficiency leads to increased risk for MS, but that's been demonstrated for decades. And then avoiding obesity and then high salt diets, those are also risk factors. So those are things that are hopefully modifiable. But I think that's probably where we're at with things. I think, it'd be very cool with this study, which has a couple hundred patients in it, if we could, get a little bit better understanding of genetics, and then looking at, what were sort of the earliest changes that developed for these patients. Okay. So the next question, how would someone with relapsing MS recognize a relapse versus an exacerbation of symptoms? And so I'll probably break this down slightly differently. So, I would say if someone with MS has new or worsening symptoms, how would you know if you were just feeling worse because you have MS and something else was maybe going on, or it was just a bad day, or that it was a brand new inflammatory attack happening? And so part of that is going to depend on what the symptom is. So if you have a brand new severe symptom, that's very unlikely to be, just the MS in the background, sort of fluctuating. We have a term that we use called a pseudo relapse or a pseudo exacerbation. So what that typically means is that one of your old MS symptoms sort of gets a little bit worse, or maybe it comes back to the surface. So that by definition is going to be triggered by some other factor. So, typically this is an infection, although things like hot weather can also be a big driver of this happening. Not sleeping, stress, But a pseudo exacerbation, or getting the flu should not cause like a brand new symptom to happen. Like if you have MS and you've never had your left arm be numb before, and your left arm goes numb and it lasts that way for a day, typically we think about a 24-hour time period, then that would be, of course, concerning that there's some new thing happening. And then, the other way that we like to look at this is, what drug are you on? Are you on a medication? How worried are we that the drug might not be working? So if you're a younger patient, you've had relapses recently, you have a brand new symptom, you're not on a medication, we're going to be really worried that it's a relapse. We're certainly still going to work it up and try to understand what's happening if you're a younger patient who's on a really effective medication, but we just have a little bit lower concern that that's the case. And although the medications are, often wonderfully effective, they also do increase the risk of getting things like urinary infections. So that is often, also sort of the other end of the spectrum, as we're having less relapses, but more of these pseudo relapses. But treated differently. So just important always to, have your neurologist help you figure that out. Question.
How would you measure smoldering MS information if you don't have a baseline? You pretty much have to have a baseline because you're measuring the inflammation, right?
Yeah, so smoldering MS, not that. So there are some like, sort of criteria for it, but I don't like to use those because they were basically written by a drug company. So, really it just, smoldering MS is, sort of a nebulous term. I think, the question is more about progression. So what do we actually care about, is how are you doing as the patient and are you getting worse or not, right? And so, one way we can sort of get a proxy for that is by looking at the MRI scan and saying, are there new lesions? The problem a lot of the time is that as we get further in MS, people are feeling worse, but we keep scanning them and the MRIs look exactly the same. So then what we're trying to develop as a field is, are there things that we can measure reliably in our patients that are better representations of sort of how they're feeling, if they're feeling worse or they're feeling the same. And so, those things we would term biomarkers, sort of a complement to MRI. And so there's a lot of different things that could be biomarkers. Some of them are things as simple as, regimented, like repeated physical exam maneuvers. One project we've been trying to get off the ground for a while are using smartphone applications to measure things like this. So, could you do a little test of hand dexterity, coordination on your smartphone, time yourself walking, do a quick memory test all on the smartphone, save it, then measure it every 2 weeks and sort of see how things were going. That would save a clinic visit. We can't, of course, see any of our patients, every 2 weeks to do this sort of thing. So it, just adds benefit there. The other is with blood testing. So this is not, quite ready for clinical use, but there are some markers that can be checked in the blood, including something called neurofilament light. So NFL, you'll see it referred to as, and that may also be a marker that changes as the MS, worsens, and perhaps with drug, may go back down and things like that. But yeah, I mean, it's very challenging initially when someone's diagnosed with progressive MS to sort of understand what that trajectory, of the disease looks like. We often have patients telling us for like 2 years that they have progressive MS before we actually see something on the exam that shows up. Part of that is that if we examined patients on a day like today, like the exam would, almost for sure look worse than if it was 25 degrees outside. So we have that, working against us. But yeah, I think, that's this detection of progression and sort of measuring it is a huge, missing piece for us. And it makes it also harder for us to do clinical trials because, it's way harder to test a drug for progression if we don't have good ways to measure it. For relapsing MS, we're not allowed to use just MRI as an outcome, but we can run a clinical trial quickly with a drug and look at, did the MRI lesions stop happening or not? We can get a pretty darn good idea if it's working. but we don't have that, capacity right now with a sort of a surrogate measure for smoldering or progressive MS. Okay. So there's a couple other questions about drugs for progressive MS. So updates on primary progressive MS, and then anything to slow down secondary progressive MS. And so for secondary progressive MS, we had talked about a little bit. So I think the bigger drug option that is hopefully going to be available is this tolebrutinib drug. This CAR T study is also enrolling patients with SPMS, as is this study. So those are all possibilities. At least in my practice, like we typically for SPMS will try to put patients on B-cell drugs, so like Ocrevus or Kesimpta, Briumvi, and just based on the primary progressive MS data. But we're hopeful to have some more options. As far as primary progressive MS, so the only study that I can recall that would include primary progressive MS patients that we are currently recruiting for is the CAR T study. Okay. And then are there remissions with secondary progressive MS, or is it just worsening of disease? And so secondary progressive MS is confusing. So it means that basically that you're sort of slowly getting worse after a period of having relapsing MS. There's really two flavors of it. So there's a flavor where you're still having attacks where you get worse, but also in between the attacks, you're getting worse. So I'll see if I can draw something out here. And then there's something called inactive SPMS, which is, in my opinion, not a very smart term because people are still getting worse, but it's technically inactive because they're not having relapses. So it's probably not the most patient-centered approach to think about it. But so for SPMS, you can just sort of slowly get worse, have a relapse, get worse very quickly, and then slowly get worse again. Inactive SPMS would just sort of be this slow worsening. Again, we think of relapsing MS as sort of like you have a relapse, then you're perfectly stable, then you have a relapse, then you're perfectly stable. And these, metrics are all just how much disability you have and then, time. So that's how I think about it. So, certainly things are not always that clean, where there's a lot of ups and downs and fluctuations with symptoms based on different factors. Yes, question.
I have a loud voice. I don't need it. So I'm told from secondary MS, I have slow progression. That kind of like what this inactive.
Yeah, so that would probably fit in that inactive secondary progressive MS camp.
Maybe you could summarize the study about discontinuing your DMT when you're in your 60s and older.
Yes. Yeah, so that I realized I didn't write down a couple other things here. So we actually ran a study, Dr. Corboy, one of my colleagues, called DISCO, so DISCO MS. And so there's a couple webinars that he talks about this for a long time about, including some recent updates from what's called an extension study. But so what the study did was it took patients who had been stable, were over 55 and had MS, and it basically randomized them and took half of them and said, stay on your drug, and half of them and said, go off your drug. And so you may ask, why would you do this? There's a few reasons that this was interesting. One reason is safety. So we know that drugs have side effects, and these side effects often get worse with time, including things like infection. So the longer you're on the drug, and then age, and then of course those two things often go together. So that was part of it. two, especially for some of the older medications, is sort of the inconvenience or annoyance of being on medications. So that's a little bit less of a day-to-day issue with some of our newer drugs, but for people on like Copaxone or Avonex, like, people often dread doing the injections of the medication. And then three is that there's a lot of evidence, that these drugs actually don't seem to be, providing a ton of benefit for patients who are older. And so typically that would be segregated at 55, but also 65. And just to be very clear, this does not apply to everyone, but this is more so like patients that get diagnosed at like a, relatively typical age with MS, so say like 30, and then are hitting 55, 60. This is not applying to people who get diagnosed with MS with like a new flare-up when they're in their 50s, for example. And so those were, among the reasons to do the study. And so it was a little bit confusing how it was set up. So it was designed as something called a non-inferiority study, which I don't really want to get into because it gives me a headache. But it was basically, we wanted to basically show that, that these strategies of being on drug and not being on drug were within some threshold of each other, as opposed to showing that one was better than the other one. And the reason is that for all those other reasons that you may not want to be on an MS drug, if it performed a little bit worse as far as stopping relapses, we probably would accept that as being okay. Because we may not have the cost, the inconvenience, the infection risk, all these other things. And so the study was not, able to actually meet the primary endpoint that it was designed to, but especially now that we have some of this extension data, which is just a longer follow-up of all the patients in the study, which Dr. Corboy recently did this webinar about, or will be doing, I don't remember. The rate of having flare-ups or disease worsening or MRI changes for any of these patients was really quite low. So most of us are pretty comfortable if someone, has a, want to go off drug or they're having side effects from drug, if they've been stable for a long time, the MRIs have been quiet, and they're older, and discussing that and potentially doing it. But this is, not a strategy that is for everyone. There's been some similar studies looking at younger patients. So in the Netherlands, they did a study called MS, which was looking at younger patients, so even into their 40s. And so that study actually had to be stopped because so many patients were having relapses. So there does seem to be an age dependency to this. Not for everyone, but definitely is a topic that we will be learning a lot more about in the next few years.
And I'll just pop in real quick to say the webinar that Dr. Corboy recently did was on July 1st, and that is on our YouTube channel and on our website. And then we also have articles and another webinar from when the disco first read out. So if you just go to mscenter.com and look for disco, you'll get all of those resources in one place.
The next question is just asking about progression of late onset MS. People diagnosed in their 50s or even 75 recently diagnosed with MS. Exercise was recommended as a treatment. What other treatments should be considered? And so I would say exercise is great. Optimizing vitamin D levels is also a very easy thing to do that might be helpful. This was not studied in older patients, but for newly diagnosed patients with MS who had low levels of vitamin D, treating them with vitamin D and normalizing those levels was actually very helpful, and seemed to, in some cases, almost be as effective as some of our old school MS medications. So that is a very efficient thing to do. I don't know, otherwise it depends on the circumstance. Like 100% have had patients that I diagnosed with MS in their 70s that had recently had relapses and put them on very aggressive treatments. Again, the age is an important contributor both to medication efficacy and side effect, but a lot of that also depends on the disease duration. With really active MS, I think we still, have a lot of I think want and need to use medications. So it just depends a little bit more on the specifics. Next question says, I was diagnosed with MS in May. I have tingling in my arms and legs. Is this a sign that I will lose mobility? So we'll start with that part. So hard to say just based on that. It depends on sort of what the cause is and where the lesions are. So there are different pathways for motor, so strength and sensation in the brain and the spinal cord. So having irritation in one of them does not necessarily mean that the other pathways are going to be impacted. But of course, it depends. There are other factors about, what's going on as far as where are the lesions and how many are there and what drug and things like that. Also, I'm experiencing severe memory loss, and I'm only 37. So these things are definitely all concerning symptoms. Definitely sounds like someone that we would, want to have on a high efficacy medication. Hard to say a whole bunch, else specifically from that standpoint, just without knowing more about the case. Any improvements or success from patients using the Cionic sleeve? So the Cionic neural sleeve is a assistive device that is supposed to help with and does help with walking for MS patients. And so, one benefit we have with MS is that it does not impact the peripheral nervous system. So it only is going to injure the brain, the optic nerve, and the spinal cord potentially, so the central nervous system. All of your nerves out in your arms and legs actually work fine, at least as far as the MS is concerned. So the Cionic neural sleeve is a device that wraps like a sleeve around the leg, and it can actually detect and then stimulate that nerve to help the foot move more normally. So especially with people with foot drop, where the foot is sort of not able to lift up as much and it can drag when walking, the neural sleeve has been shown to have a pretty significant benefit. So I have several patients that have the Cionic neural sleeve. We do have a special physical therapy clinic at the university that helps people, try this out and does some evaluations and sees if it might be helpful for them. So I know that's, very far from here, 4.5 hours, depending on the day. I don't know, about locally here in Grand Junction, how much the physical therapists have used that, but it's definitely something to inquire about. Yes, question.
Is it neural?
Yeah, I'll write it up for you.
Is there such a thing as neuropathy? Is it neuropathy that's happening in the appendages like the arms and feet, or is it something completely different?
We sort of like to use confusing terms. Neuropathy, if you talk to a neurologist, neuropathy is going to be some sort of injury to the peripheral nerves, so the nerves like in the arms or the legs. And so MS should not cause that, but there's a lot of other things that are common that can cause neuropathy. Diabetes, B12 deficiency, alcohol use, different medications, even age or genetic conditions. That's often something that can pop up as sort of a complementary, issue that happens to the MS. We don't typically use the term neuropathy for, injury to the brain and spinal cord cells themselves, which is where MS is the issue. Yeah, it's a little bit confusing because we do use the term neuropathic pain all the time, and that can happen from the brain or the spinal cord and does.
Is it common for someone with MS to have neuropathic pain or nerve pain in their feet?
So it is actually quite common to have neuropathic pain with MS, and so what we think happens with that is that the sensory pathways, especially in the spinal cord or a part of the brain called the thalamus, can get irritated and damaged by the MS. They don't totally die. Instead, they short circuit and sort of send false signals. And the brain typically interprets that as pain. So The feet can certainly be a common place for that to happen, especially with lesions in the thoracic spine, so the lower or middle half of the or middle third of the spinal cord. There are a lot of medications that can help with that as far as slowing down those pain signals. So that's definitely something that's worth talking to your neurologist about. We don't really have a way to fix the problem. I mean, this is something that stem cells or other things have been proposed as potentially being able to help, but we do have quite a bit of medications that can slow down at least how bothersome those symptoms are. Okay. Next one's a little bit hard to answer. Will government cuts affect MS programs? I think yes, invariably on many different levels, including provision of healthcare through things like Medicaid, federal research funding, which is where most laboratory science is funded by the federal government. And then even things like grants for different sorts of outreach programs. So I don't know a way around that other than to try to lobby your politicians as a constituent. But I think unfortunately we are concerned about the impact of some of these government cuts on our patients on several different levels. Okay, and then we asked about AI earlier. There's a question about hepatitis B. If a patient was exposed to hepatitis B but was immune, did not have active hepatitis B, and had some negative blood testing, how likely would it be that a patient would get hepatitis B after starting an MS drug? So I think I'm going to pivot a little bit from this. We can answer it, but we'll talk a little bit more broadly as well. So the crux of the question is really just about two things. One is about infections with MS drugs and screening, and the other one is about vaccinations. So hepatitis B is of particular interest, with MS, not because of anything specific to the disease, but because having a hepatitis B infection, if you're on medication that is a B cell depleting drug, like rituximab, Ocrevus, Kesimpta, can be very, very dangerous. So we screen every single patient in our clinic for hepatitis B, and then ideally we vaccinate them. Most people have gotten hepatitis B vaccine at some point. It doesn't always work, so we like to check, because sometimes we have to give it to people over again. And so that's why we're checking. Tecfidera, I would still wonder about it, but it's not been demonstrated to be a drug that we really get worried about hepatitis B specifically. If I remember correctly, for the clinical trials for Tecfidera, they didn't screen the patients for hepatitis B, and nobody got hepatitis B like reactivation or infection during the study, as far as I know. So I would be less worried about it. For the drugs like Ocrevus, Kesimpta, rituximab, Briumvi, for those drugs, if there's been a past hepatitis B infection, we, typically will either not use the drug, or we'll put the patient on an antiviral to reduce the risk of the disease reactivating. This is often, this question is often helped by consultation with either the infectious disease doctors or the liver doctors, the hepatologists, just to make sure that we're not going to, cause some kind of problem. And also people tend to get rather confused about interpreting hepatitis B results, just because there's a lot of different tests that can be sent, so they can often make sure that we're at least approaching the problem correctly.
Dr. Wolf, could you please speak to the risks that the West Nile virus poses to patients on anti-CD20 drugs?
Oh, great question. So West Nile virus is a virus that is spread by mosquitoes. So West Nile has been in the US since the mid to late 1990s. Probably not as much of a hot spot out here, but still can occur. But on the Front Range, especially up in Larimer County, is a huge hotspot in Weld County for West Nile. So West Nile most of the time is not really going to cause any significant symptoms. The problem is that for patients who are on immunosuppressive drugs or are immunosuppressed for other reasons like cancers or genetic diseases, it can be very dangerous and cause something called neuroinvasive West Nile. So neuroinvasive West Nile can have a number of manifestations, including injuring the spinal cord, injuring the brain, causing meningitis, and can often lead to people being in the hospital, in the ICU, and dying from the disease. So this is especially a concern for patients on B-cell medication, depleting medications. So again, Ocrevus, rituximab, Kesimpta, Briumvi, because those drugs work really well for MS, but the way that they work blunts part of the immune system that is really important for fighting off the West Nile infection. So we recently finished a study just on our UC health patients, looking at this patient population on these drugs, and just really demonstrated that a sizable percentage of them, although the infection is uncommon, get quite sick, end up in the ICU, and end up with still having deficits from the infection at 90 days of follow-up, which is the typical way we look at, how did they do longer term. So I think, I personally would not, change what medication you're on if it's working for the MS because of this, because although this is a severe infection, it is not very common. But I would say that it is important, especially this time of year, to be careful about exposures to mosquitoes. And this is also not the only disease that can be spread by mosquitoes. And so West Nile season is sort of, June, July, until it freezes twice, basically, is what we think about. So we just had the first mosquitoes test positive for West Nile in Denver because there's surveillance programs for that, I think about 6 days ago. As far as I know, we have not had any confirmed West Nile cases in humans, but it just is a matter of time. So there's, we could perhaps send out a link. There's some nice guidance about mosquito, sort of how to avoid mosquito bites and things like that, put forth by the CDC, but wearing long sleeves and mosquito repellent, staying away from from standing water, things like that are probably the easiest ones to do. But there's some more detailed advice that we could also provide.
I have two MRI questions. How often does a person have an MRI to assess? How often should people with MS have an MRI?
Yeah, everyone with MS or being worked up for MS should have a brain, cervical spine, and thoracic spine MRI at the time that they're being evaluated or diagnosed, because we want to look at all the areas that might be important or be impacted by the MS. And then after that, it depends a little bit on which doctor you're seeing, which drug you're on, and how you're feeling. So for my patients who are on high efficacy medications, we would be surprised to see any new lesions. So if they're feeling fine, we typically just get an MRI of their brain about 1 time per year. If I have patients who I'm worried about from new symptoms, or they're on a medication that I don't think is going to be as effective, we may do that every 6 months. We may also image the spinal cord more frequently. The reason that we tend to focus on the brain more than the spinal cord for surveillance imaging or these follow-up images is just that it's much less likely to have symptoms from a brain lesion, so we don't want to miss something that's happening sort of beneath the surface. So traditional teaching would be that 80% plus of lesions in the brain actually do not cause symptoms right away. And the reason is that there's a lot of redundancy. The lesions are not very big. Your brain is relatively pretty big. So it would not be too hard to have little dots there that we didn't notice. So we certainly don't want to have that happen a bunch of times when it then starts to cause symptoms. That's why we tend to focus in on that. The spinal cord is much smaller. So your spinal cord, for all of you, is probably about the same diameter, roughly, as your pinky finger. So it doesn't take a lot of injury there to, notice symptoms. There's not a lot of redundancy or backup there. So, traditionally we thought like 80% of spinal cord lesions would cause new symptoms. I think every time we get more powerful MRI scanners, we're probably a little bit humbled about some of these things. But that, still is why we tend to focus more on the brain MRIs for follow-up, just with the thought that, if you had a spine lesion, you'd probably have new symptoms.
And then the second question has to do with contrast. So can you talk about contrast generally, if people need to do that, or how often? And then specifically, this patient just started a DMT but has an extreme needle phobia. So she's wondering, push through the needle phobia, get the contrast, or skip it?
Yeah, contrast dye for MRIs, very important to get if we do not know what's going on with you. So at the time of diagnosis, it's very helpful for that reason, because distinguishing MS, tumors, strokes, etc., can actually be very helpful. It's also helpful at the time of the diagnosis to sort of understand how long have the lesions been there. And so IV contrast dye will typically light up a brain lesion from MS for somewhere around a month to 3 months, but it's not going to light up the lesion for years at a time. So it's often helpful for us to understand something as MS if we see lesions that are light up and ones that are not. So it's often helpful early in the disease process. I almost never get contrasted MRIs for follow-up, partially because it's not that helpful. So we have a comparison MRI, like a baseline, and we get a new MRI, we're going to be able just to count what are called the T2 lesions, which do not need contrast to count. So that doesn't help us. It adds more time to the MRI scanner time. It adds more cost. People hate needles. They might have a contrast allergy. So I personally don't do that for follow-up studies. There may be specific reasons, like if a patient has new symptoms or something, that it would be helpful, but I would say probably 95% of our follow-up scans at the university, for all of our MDs are done without contrast.
It's a headline associating use of gabapentin with cognitive decline.
Yeah, so the question is about gabapentin, and is this a safe medication, especially with cognition? So there's a few meds that we use that we are worried about sort of long term. Probably the one that I get the most concerned about in clinic are like some of the over-the-counter sleep medications that have Benadryl or other antihistamines in them. The other ones are for people taking chronic benzodiazepines. So we used to use a lot of drugs like clonazepam, so Klonopin, or Valium, diazepam, to treat like spasms and help with sleep and things like that. So those drugs are pretty unequivocally showing that, especially at higher doses, can cause risk of cognitive issues as people get older. Gabapentin, I don't know if I've seen the exact study that might have been referenced. Gabapentin is used a lot as a neuropathic pain medication in MS. One caution with it that we're typically thinking about, we don't prescribe a lot of opioids like oxycodone in the MS clinic, but it's always important with gabapentin because those drugs together can be really dangerous combination. But gabapentin, has been around forever as a seizure medication where people have been on moderate doses of it. As far as I know, I haven't seen evidence specifically in those populations of causing cognitive issues, but I'm not sure how well it was tested. The dosing range for gabapentin is pretty big, meaning that I have patients that take like 100 milligrams a day of it, and like that works for them. And then I have patients that take the maximum, which is 3,600 milligrams a day. So I don't know. I'd have to look specifically at the study that was completed just to weigh in on it. But we do use it, a lot, and I haven't personally seen a lot of huge issues with it.
Do you have any information on the use of medicinal mushrooms for MS?
I don't have a lot. So this is a question we've been getting like pretty frequently. There's actually very little basic like lab evidence and almost no clinical evidence about it. I'm sure if we were to reassess this in a couple of years, we'd probably know more. We get similar sort of questions about cannabis products. I think that one also is still pretty limited as far as what we know. We do know that a lot of our patients use cannabis products to help predominantly with symptoms. We did a study a couple of years ago that showed perhaps as many as 40% of our patients were doing that, mostly for pain and sleep symptoms. But we, for a few different reasons, have not been able to do clinical trials to look at this in a huge amount of detail. The last question I had on here says, I had a clinical trial canceled. I will age out of more clinical trials, so I'm desperate to find a lab or a hospital doing either stem cell treatments or exosome treatments. Can you recommend anyone doing these types of therapies? Okay, so let's talk about a couple things. I want to talk about we'll talk about exosomes first. So exosomes are sort of like little envelopes of chemicals that your cells will use to communicate with each other. So they potentially may be anti-inflammatory or help with remyelination or things like that. No real evidence for using exosomal therapies, right now with MS. I looked a little bit earlier. There are not any clinical trials specifically doing this that I could find. Stem cells, there's more to talk about. So I think with stem cells, there's always sort of two different camps that we're thinking about. So one is with a stem cell transplantation, and then the other is stem cells as a sort of neuro regenerative, like repair the brain or spinal cord therapy. And so those things are quite different. So stem cell transplant has been done, again, initially for cancers, but has been done for MS for, at least 20 years at this point. We know that stem cell transplant is an effective therapy for MS if it's relapsing MS. So we probably have 1 or 2 patients a year that do not do well on the conventional MS therapies and just keep having relapses. And the typical course of action would be to refer them for stem cell transplant, at least as a consideration. And so how that works is the stem cell transplant, basically you get high dose chemotherapy, it kills the immune system, and then you get some of the stem cells back from your own body to sort of regenerate the immune system, hopefully without the trigger that causes MS. And so, that we know that works. It has a lot of toxicity or side effects. It tends to be perhaps more front loaded, meaning that you might get this and end up in the hospital or the ICU for weeks. And then have some complications, but then you may be able to be off of an MS drug for several years, if not forever. We don't have perfect follow-up for these patients. There's some question about, how much more effective this is than drugs like Ocrevus, Kesimpta, Tysabri, those current high efficacy drugs. So we've been part of a clinical trial for the last few years called Beat MS. And so that is attempting to compare patients on stem cell after stem cell transplant to patients randomized to these medications. I think honestly, it's been hard to recruit for because most patients are just going on the high efficacy normal drugs and they're doing fine. So they don't want to get have the risk of getting a stem cell transplant. We don't have the same data that's helpful for progressive MS. We're hoping to be part of a study using a brand new stem cell transplant method for progressive MS in the next hopefully 6 months. But that is not something that is currently up and running. But you'll certainly hear more about that should we get that started. The other piece of stem cells is that regenerative piece. So do we have a way to like the promise of stem cells, of like giving stem cells back to people to, you know, have them go in and like repair damage. And so that, you know, that remains, you know, stuck in very early stage trials where that's been tried in different aspects. It's not yet been shown to work. There's some evidence that it is tolerated okay, but it is, you know, pretty far from being, you know, ready for prime time as a treatment. I think, you know, one particular interest of mine, just to comment on from that standpoint, is, you know, the fact that this is not something that is proven either to be effective or safe does not mean that you cannot find some place to get this done. So that always, you know, really concerns me, because there's pretty lax regulations actually on how these products are offered. So you for sure in the US, or like one of my patients in Mexico could get, you know, stem cells injected into your spinal cord. And, you know, that can sometimes have some catastrophic complications, either from things like infections or tumors, or just getting ripped off and getting, you know, water pushed into your veins or things like that instead of stem cells. So that always really concerns me. I think, you know, when there's a good study happening for stem cells, you know, we will for sure try to be part of it. Yes.
Look at what are other countries doing, like Eastern countries and Germany and other medical. Is there any collaboration in there or collaborative efforts?
Yeah, so the question is just about research in other places. And so, you know, as far as stuff that is the heaviest for MS research is mostly in Northern Europe, just, you know, predominantly based on the epidemiology. So, you know, places that have a lot of MS, you know, besides Colorado, are, you know, Sweden, Norway, Denmark, Germany, UK. And so there's been a lot of research on different things in these places. So I think, you know, we actually have learned a tremendous amount about B cell medications. So drugs like rituximab from studies in Sweden, as well as in Denmark. We've learned a lot about sort of early use of this CAR T therapy from sites in Germany. You know, I think the one that, as far as things we have not really talked about, so from the UK, so the collaborative groups in the UK with the National Health Service and others have, you know, looked at a lot more of sort of using medications that are already available to try to help with progressive MS and with remyelination. So they just finished about 6 months ago or so a study looking at statins. So some of you might take statins for your cholesterol. Statins have a lot of other effects on the body. And so the thought was they may actually help from an anti-inflammatory standpoint. So that study did not work, unfortunately. So it did not show a benefit to taking statins for MS patients. However, the study did show that the big group to do big studies was able to work really well together and design a study and get patients enrolled in it, which is not always the easiest for progressive studies. And so there's a couple studies looking now combined in the UK looking at metformin, which is a blood sugar medication that may have some anti-inflammatory properties, and then also clemistine, which is that other medication that I had mentioned earlier that we're looking at for myelin. But those are probably the big things. You know, I think there has been a little bit of a shift to, you know, maybe to having to lean on the European groups for doing more research, just if we have our funding all, you know, cut in half here. So, you know, the EU actually has been trying to steal a bunch of basic scientists, so lab scientists from the US in the last like 3 months. So they had put together like $1 billion to, you know, they're just like calling up like all the Nobel Prize winners in the US and asking them if they want to come to, you know, Germany or London or wherever. So we'll see what happens. But I think as long as somebody's doing the work, we're happy to use it.
I was curious if you saw the study from the Netherlands that talked about myelin being the secondary target, and it was something with the astrocytes were actually the primary target of the disease, and the myelin was kind of secondary, but that's what we see.
So yeah, question about where is the sort of first injury in MS and what is like a reactive issue? Are there targets, on astrocytes in addition to myelin for the immune system? This is actually a very good question. So, like a year or two ago, we were getting a lot of questions about this thing called the reverse vaccine that might like turn off parts of the immune system that were resulting in dangerous inflammation in MS. I think so that the issue that we have, I don't think we know exactly what the initial event is with MS, and we know that there's a lot of different targets for the immune system. There's a disease that we used to think of as sort of a variant of MS called aquaportin 4 neuromyelitis optica, so fancy words, but can cause demyelination in the spinal cord and the optic nerve, as well as the brain. And so we used to think that was bad MS. Later on, we identified that there was, one very specific target, something called aquaportin 4, that there was inflammation against. And so theoretically, which is being worked on, if we manage to turn off that specific, issue, and that block that specific target with something called tolerization, we could, potentially stop that disease from causing problems. The issue with MS is there's probably like, at least 300, if not more, like different targets that are being impacted, different proteins on the myelin, different things on the astrocytes, different things on the axons of the nerve cells. So it's much more challenging for us. And I think that's where, there's probably more approaches to look at. I don't know if Dr. Vollmer, who was at our center but retired a couple of years ago, he, at least on the neurology side of things, had done a few like very prolonged lectures on like astrocyte biology and MS, but I don't know if those were ever like recorded as part of one of these. They might have been a little bit more like wonky, like scientific stuff. Yeah, it's an interesting thought.
Can you speak to how common sexual dysfunction is for both men and women with MS?
So sexual dysfunction in MS, so that can be common for men or for women. And I think there's probably two camps of it. So one is due to the MS lesions. So especially lesions in the spinal cord can cause things like erectile dysfunction, among other issues. The second piece is medications. So some of our medications, especially for people on antidepressant medications, can have sexual dysfunction. But yes, it's a quite common symptom. We are admittedly not great at managing it. So sort of similar to fatigue, that these are things that we still struggle with.
All right, I think that is all that we have for tonight. Thank you guys for so many great questions being submitted. We covered a lot of really great topics and a lot of topics that we have additional resources on our website or YouTube for. So I just wanted to make sure that everyone knows, if you go to mscenter.org or YouTube/the MS Center, and then there's a search bar. And if you search for certain terms, you will get not only like full-length webinars and articles that we've done, but also all of these conversations events. A lot of the questions like smoldering MS, aging out of treatment, diet, nutrition, all of those things get asked pretty frequently at these events. And I think it's really awesome that we do it with different doctors, so you can hear different doctors say things in different ways. And all of those topics are linked in the YouTube. So if you search for smoldering MS, you're going to get every video that we've mentioned smoldering MS in. So that's a really cool feature that we actually put a lot of time into making happen. So yeah, smoldering MS, we've discussed it at the Ed Summit, we've discussed it at Conversations. The Disco MS results, we've done that a few times. BTK and CAR T medications, we have separate presentations and articles on both of those. The idea of relapses versus pseudo relapses, all of those have, again, articles and video presentations. So strongly recommend checking out our website. If you would like the links just sent to you straight, my email address, you can just email me. My email address is education@mscenter.org. And I'm always happy to help be a resource for you as well. So thank you guys for joining us. I know it was Friday, it was hot, and you guys brought great questions. So thank you, and thank you, Dr. Wolf.